Sensill is disrupting medical diagnostics by creating real-time testing for skin infections, including bacteria. By looking at the mechanisms dogs use for detecting various things via smell, they developed and patented a point-of-care device that can provide real-time information to doctors treating skin-related issues. The applications for such technology seem limitless, and it looks like it will revolutionize diagnostics and how they are treated. The founder is Dr. Ardeshir Bayat, a well-published doctor and expert in skin diagnostics. Let's see what he had to say. Hello, everyone. We're here with Dr. Ardeshir Bayat of Sensill. Hi, Ardeshir.
Hi there.
Welcome.
Thank you.
So, can you tell our viewers a little bit about your background and how you got into Sensill from the beginning, like how you came to this point, like before you started Sensill?
Gosh, long journey. Takes takes me back to probably 2000 and what, 8, 9. I think it was this experience of I'm a clinician scientist. I was seeing patients and I walked into this cubicle, and first thing that sort of overpowered me was this terrible smell of this patient's infection that I was asked to see, and to such a degree I thought I was going to pass out, and then I had to put double mask and then go in and examine this patient and came out, and then in the evening I was just thinking about the experience, thinking, gosh, incredible how pungent and powerful that experience was. And being a dog owner, I've always loved dogs, and I was also trying to relate the finding that how dogs are so incredible at sniffing things,
Yeah.
and the ability to sniff molecules out is a lot greater than other species, in particularly man. And then I thought, well, what if I'm just putting two and two together, and I was thinking, what if we could somehow emulate what dogs do and sniff out infections sooner? So, come a year later, I started this project. I had my own lab. I was working in a university hospital, and I set up this project where we developed a technique of looking at volatiles, these molecules that become then this smell, how we can then characterize them and identify whether there is a way of trapping these volatiles that are emitted by bacteria and fungi. And lo and behold, we managed this by a technique that we developed where we'd use a highly adsorbent material on a culture dish and or on the human skin, and we could trap the volatiles at different concentrations. And then we used a lab bench-based technology, which is called GCMS, and that could then analyze the volatiles, and they were so specific and to such a degree that when we had the readout, we could then relate that to a particular bacteria and or fungi. So this led to a number of publications and a number of studies that I did using that technology. And then time passed. The first publication I had on the topic was about 2010, and the last on the topic was 2020. And so when I finished my last publication, I thought, well, wish we could somehow translate this to from the bench to the bedside, and we could have a portable device. And before you know it, it was the advent of COVID, pandemic started, and that created an opportunity for me to really think this technology out and look at what else we could do with this approach. And that's when I put two and two together, and I was thinking about the concept of how one volatile, the most common volatile most people know about is ethanol. How we can capture and identify that. You know, if you drink too much, there are ways of capturing it, and the more you drink, the more that would show on the device. And so this, what really sort of started off and led to the concept of how we can use this technology called colorimetric sensor arrays, where we have many dyes that react very specifically with these volatiles. And it's that pattern that we can then use at a point of care non-invasively to read out what bacteria, what fungus would be present there. So that's been the journey. It started many years ago, but the company wasn't formed really until we actually went into our labs in May of 22. And since May of 22, our labs in Northern California, East Bayside, where all the greatest talents were at the time for this type of work. And we managed to complete all our milestones for our seed stage funding. We'd received pretty much immediately after we told people what we were going to do, because no one could believe that you could do point of care testing non-invasively in real time. And that led to 12 patents, and 12 patents later, here we are at the juncture of our Series A.
Wow, that's an amazing story. I want to ask you something about when you said volatiles. So, are you saying that this is explanation for our viewers that every smell has a molecule that you can somehow identify, like the difference between smell A and smell B? If you're looking at the on a molecular level, it's obvious for you to figure it out with using sensors or
Yes, absolutely. I mean, like dogs, when they sniff out explosives as opposed to, their food or other dogs' urine and or anything else, they don't have these compartments in their brain where it says one area says, this is for detection of explosives, this is for detection of money or whatever else. They have set of receptors, and these receptors, each one of them reacts with these molecules, and it's the readout of those molecules that's the digital imprint in their brain, and that it sort of tells the dog what it is that they're smelling. And it's the same thing, you'd either use, we can't really replicate those receptors outside of a dog's head. There are no machines that can do that yet. But if you imagine that these dyes are almost like a receptor and each one reacts with this molecule, then if you have a set of dyes, and we developed a barcode of dyes, we robotically printed these dyes, different colors and different chemistries. And then each one of these molecules is reacting differently with which one of these dyes. And it's the pattern that emerges, which is very unique at the end of that. And that's really what the dog senses. And that's what the volatile um, signature is, a combination of those molecules that then defines the scent of, for example, cinnamon, or the scent of vanilla, or the scent of explosive, or the scent of, someone not having had a wash, all of that kind of thing.
so you've recreated the super scent of the dog.
We're not, I think we've got a long way to compete with the Almighty in the in the evolution of the dog's olfactory sense, but I think we have something that is very credible and repeatable, and in fact that has been validated many times over in our lab, showing that whether you have the bug grown in a dish or in a culture broth. And we did this work again before as well. When I published the work originally, we did grow these bugs not only in a test tube, but also on a cover slide, and also then on human skin before we went into clinical studies. And we showed that in all of those parameters, you can identify the bug, and the bug that's more concentrated will have more emission of volatile. And that's what happens when you haven't had a wash. If you have a wash, you're not getting rid of all the bugs on your skin, you're just reducing the concentration. So the more bugs there is, the more metabolism there is. There's more DNA, the more metabolism, there's more emission of volatiles. And that's why someone who hasn't had a wash won't smell very good. And that's because there's a high concentration of volatile producing bacteria.
What do you think, if in one sentence or a couple sentences, what is the most valuable argument, the biggest value argument for hospitals, clinics at the point of care that's using this versus what we do today?
One word, real time. If you imagine all diagnoses that are based on measuring, for example, genes and proteins, and they tell you an event or give you some information, but they are not in real time. Metabolism is the only thing that's real time, that's happening right now. And metabolites that come as a result that are emitted by volatile by bacteria and fungi are in the form of volatiles. They are a real time indication of what is happening. Um, so in a way that it can correlate it to pulse oximetry. Pulse oximetry, if you go into any hospital, they put that um, on a digit, either hand or toe, depending on what they're looking at, and then they're looking at oxygenation of your blood. Now, that is almost like mandated in every hospital where they would have to do that, because it's instant and it tells you instantly what the level of oxygenation is. Before, they used to do arterial blood gases, where they would puncture an artery such as the radial artery, take a sample, go to a machine, and that readout wasn't in real time.
Hmm.
So even though pulse oximetry, they could still do oxygenation readouts, pulse oximetry just was transformative in instant, real time diagnostics for looking at oxygenation of blood. Now, the same thing would be in this scenario where we have a real time, instant diagnostic readout of the presence of bacteria or fungi, rather than taking a sample, which is what's happening now, sending it away to a culture lab somewhere else, and then taking 2 weeks for that to come back, 2 days for that to come back. In the meantime, most people will get um, a prescription of a blind prescription of antibiotics and or antifungals, and then after, and 2/3 of these are generally wrong. So they, and frankly, the reports are that only 11% of people who are getting antibiotics are getting optimal treatment. So these figures are quite worrying, and the only reason for that is that the physicians don't have the means of making a diagnostic decision at the point of care, and therefore they have to treat patients blindly with broad spectrum antibiotics, for example, because they don't have that real time instant readout.
Yeah, and that's a great point. And also, you're trusting the labs to be correct. It's not with this example, but there are cases against the labs that the results aren't necessarily accurate. Uh,
Well, there's going to bound to be some prone to errors, and the problem isn't just that. Also, I think the act of taking a sample is quite invasive and it can be painful.
yeah,
And then it can't be repeated easily, because the patient then will leave the hospital, and then every time it takes two to 3 days for the result to come back. So not only is there a problem in the immediate diagnosis, but also there is a problem in monitoring the response to treatment. And that's why a lot of people go on these open loop regimens of treatment. So Joe, you look like a very fit man, but imagine that if you go in with someone who's quite frail, you both get the same
yeah, that's not.
prescription of antibiotics for the same period of time, because that open loop regimen guarantees that you both will have the best outcome from a defensive medical perspective. But actually, if we had a way of monitoring your response to that treatment, you may have to only use the antibiotics for a shorter period of time than someone who is more frail and may require even longer period of treatment for a presumed infection. So a lot of our current management or treatment of infection is open loop. And that's not good, because the problem with that is that it can lead to a global issue, which is of major concern. That's called AMR, antimicrobial resistance. And that is a concern for most doctors. It should be a concern for all patients who are taking unnecessary medication or inappropriate medication as well, because it can lead to morbidity, side effects such as overgrowth of other bugs. Clostridium difficile infection is a major side effect and can lead to major deaths and morbidity, huge costs to the hospitals, to the patient, to the health service, and then probably ultimately to readmission and a worse scenario would be mortality. But all of these outcomes are because the initial diagnosis and the monitoring has not been as ideal as possible.
That's very disruptive what you're describing. Because yeah, even in our business, a blanket recommendation is sort of against the rules, because how can one recommendation be the same for everyone? And with medicine, I mean, of course, what works for me doesn't necessarily even work for other healthy people, because we're all so different. How can it possibly be that you know, that's definitely wrong. So that's very transformative what you're describing.
This is the holy grail of personalized medical management, where you would tailor or target a treatment based on an individual's needs. You can't really do that if you don't have any means or gauge of quantifying that response, because
Yeah,
then you have to take the law of averages. Law of averages says that, yeah, if you're an adult, it doesn't matter what background size, and you just give them the average treatment and hopefully it will work. That is the case if the treatment doesn't have any undesirable side effects.
yeah,
When you have undesirable side effects, such as the emergence of resistant organisms, clearing out all the good bacteria from your gut, which we now know with the advent of better understanding of the microbiome, that's not a good idea. Um, so, and then the worst end of the spectrum is increased morbidity and potential mortality. And that therefore begs the question, what can we do to personalize medicine more accurately? And I think what needs to happen is really a quantitative, real-time measurement that can be repeated non-invasively anytime. And these are the key words here are the fact that it's real-time, meaning it's instant, and that it's non-invasive. Because
yeah,
yes, there are many measurements you can do, but if you don't want to keep taking chunk of biopsy out,
yeah,
someone out, or if you remember during the COVID days, they had this horrible swab they used to shove into your nose, almost like a cranial biopsy,
yeah,
and that wasn't a pleasant experience. And then having to wait for 24 hours often for the PCR result to come back meant you could have missed the flight because your result wasn't ready. Why do we need to do those things? Because that technology required you to take a sample
yeah,
and then to send it off to a lab where they did a PCR test.
yeah,
Those were the requirements because they were using that technology. Now, if we are using a different technology where we're just purely looking at the metabolite readout, and that's at the point of care in real time, we don't need to do any of those things, meaning your sample doesn't have to go to a lab. It's real time. It can be measured time and time again. And if our offering would be a disposable pad that could be placed on the skin anywhere in the body, whether it's on intact skin or on a wound, and then you get an immediate readout.
Would this be possible to use this for things beyond the skin? Other types of testing, like urine testing or other?
Yes, absolutely. Any kind of body fluid that has a volatile emission, it would be ideal for this use. Our focus is immediately the skin, the largest organ in the body, but there's no reason why the same technology can't be used for these other areas. Absolutely.
That's great. There's obviously a huge application for this, and it sounds like the possibilities are endless.
They are. And I feel with every technology, you need to establish its validity using one uh, area of unmet need, hopefully of the
Yeah,
greatest need. Although, if you talk to different physicians and different people of different background, probably each one of those entities has a priority. But I got interested in this because my background was an expert in skin healing, and I was dealing with wounds, published extensively on the topic. And when I was seeing these wounds, and that's what really sort of started me off on this journey. In fact, my first paper was measuring volatiles emitted from chronic wounds, because chronic wounds typically are the ones that harbor a lot of bacteria. And the reason they're called chronic is because they don't heal within a certain period of time, and they're colonized by these bacteria. Some of them become pathogenic. We call them biofilm, and there will be an odor, and we were able to detect that. and that was very diagnostic, prescriptive, and at the time quite revolutionary, because no one done that for wounds. But now being able to take it beyond that and making a portable device that can look at both intact skin and breached skin, which is what we call a wound, in any scenario, meaning it can be a burn wound, it can be a traumatic wound, it can be a long-standing chronic wound, it can be a pressure ulcer, it can be a diabetic foot wound, surgical site infection post-operation, or indeed an intact wound that's become intact skin that shows display signs of infection such as cellulitis. And all of these can then be looked at non-invasively at a point of care with repeat testing, so that you can potentially in the future tailor treatment to that.
That's amazing. Well, where can people learn more about Sensill? I'll put the website in the description, but is it mostly on the website?
Yeah, we have a website, sensill.com, which is fairly limited, but if there are any investors who are interested in learning more, please contact Joe, yourself, or via you come to me, and then we'll be delighted to tell them more about Sensill and the possibilities and where we are with the development of the program, and where we'd like to be in 2 years from now, very likely in commercialization. One thing I didn't say is because of our approach and predicate device here, we'll most likely be considered as a FDA class 1 for a general indication
Mhm.
of identifying and quantifying infection. So that means our route to market is much quicker than some of the other diagnostic approaches.
Great, that's fantastic. Well, I'm sure that everyone is fascinated with this talk, so we appreciate you taking the time and look forward to seeing this technology flourish. And we'll check back in some time and see how things are going.
It's a pleasure. Thank you, Joe.
Thank you. Have a great day.